Welcome back to the Ninja Nerd Podcast. Today we're talking about lymphoma. It's going to be an awesome episode. We're doing two cases, one on Hodgkin lymphoma and the other one on non-Hodgkin lymphoma. But the first one's a surprise. You got to try and figure it out.
I think so.
All right, let's get right into it. Case 1. We have a 25-year-old male presents with progressive fatigue and painless neck swelling for the past 3 months. The patient noticed a painless mass on his right side of his neck, which has slowly enlarged. He also reports intermittent low-grade fevers, drenching night sweats, and unexplained weight loss. There's some B symptoms right there.
Yeah.
He denies recent infections, cough, hemoptysis, or significant bruising and bleeding. Real quick, B symptoms. What? I thought it was called like constitutional symptoms or systemic type.
The same thing.
What's the B?
I don't really know what the B is actually.
Body? I just wonder. I mean,
it's truly a good question.
B symptoms.
I never really thought about that. But yeah, you can kind of call them constitutional symptoms, but for some reason they kind of just, I don't know if it's because of the B lymphocytes. I don't know. It may be a possible thing like that, but I'll have to look it up.
If you guys know, please comment down below.
Yeah, that'd be a good one, actually.
Be cool to know. Hey, He doesn't know everything. He's not that good.
No, I'm not, man. I really am not. But yeah, I think that constitutional symptoms, B symptoms, I'm guessing the B symptoms may have something to do with the B lymphocytes or something. I don't know.
Let's get into it.
All right, hit me.
Past medical history. No significant past medical history, no prior history of malignancy, no known immunodeficiency. He's on no medications. His exam, vitals, BP 125 over 80, heart rate is 85, temp is 37.8 Celsius, his O2 sat, 99% on room air. For his lymph nodes, they are firm, non-tender, right cervical, and a supraclavicular lymphadenopathy. Abdomen, no hepatosplenomegaly. Skin, no petechiae or ecchymosis. We get a whole bunch of labs and a little bit of imaging as well. Let's start off with the labs first. We have a hemoglobin of 12.5, platelets of 180,000, a white blood cell count of 8,500, peripheral smear, and it shows no blasts, mild normocytic anemia. His ESR is elevated, LDH mildly elevated. We get some imaging now. Chest x-ray. We have a mediastinal mass. Okay. Lymph node biopsy. We note Reed-Sternberg cells and a positive CD15 and CD30. And then we also get a PET CT, and we note multiple enlarged nodes in cervical and mediastinal regions. Real quick, Zach, for these findings, would this be like more incidental, or would these be like he would be much more symptomatic?
So with this one, I think like whoever started the workup up with having this lymphadenopathy, that would be the big thing, would be lymphadenopathy and the B symptoms. That's kind of the biggest symptomatology that I would see in this patient to suspect lymphoma. The other things that they potentially found as a result from the labs and imaging, I think some of them, maybe there was, the first thing I would have said is if I have a patient who has lymphadenopathy and B symptoms, would be consider working up for like an infection. Could there be something else that's going on? And so a CBC was pretty helpful in that. And hemoglobin, there's some mild anemia. Platelets are pretty much normal. White cell count's normal. So there's no evidence of kind of like any infection or inflammation, at least in that scenario. And the peripheral smear just really doesn't show any kind of blast that would suggest like maybe like a leukemia. Yeah. And if the white cell count was pretty high, maybe it could have been a leukemia as well that have infiltrated into a lymph node. So that was helpful as well. But chest x-ray, they didn't have any symptoms. So I didn't see any symptoms of cough or dyspnea or any kind of like dysphagia or anything like that would suggest from a mediastinal mass causing compression. So that was probably just an incidental finding, which actually happens pretty often. When patients have like Hodgkin lymphoma, the most common subtype, which we'll talk about, is called nodular sclerosis, that typically likes to hit the mediastinal lymph nodes, and it'll cause the enlargement of those. They can be completely asymptomatic. 50% of the time, they're probably incidental findings. You get a chest x-ray CT for something else, and you happen to kind of meander upon them. But this is a pretty good workup here on this patient.
Definitely. And if you note, we also see that he has cervical, we see supraclavicular, and now with the chest x-ray, we also have a mediastinal mass. So it is following a little bit of a pattern at this point.
That's the key thing with like Hodgkin lymphoma, is that whenever you have like someone who has a very, let's say, contiguous spread, so having lymphadenopathy that targets the cervical, that's the most common. 70% of the time when patients have lymphadenopathy and it's due to lymphoma, it's probably cervical that's most involved. So it starts there, but then it spreads, and so you'll go from your cervical, and you can kind of bifurcate. If you think about it, you can go down into the mediastinum, and you can go to the supraclavicular, and then from supraclavicular you go to axillary. And then from mediastinal, you could have abdominal down to the inguinal ones. So this one kind of has a nice contiguous spread to it. And then lymphadenopathy that is not painful, where it's more painless, it's firm, that really suggests more of a malignancy than it does kind of what's called a shoddy or a reactive lymph node due to like an infection or inflammation. So this like right here really screams Hodgkin lymphoma, especially lymphoma in general, just because lymphadenopathy, B symptoms, and lymphadenopathy is contiguous, it seems. It's gone from cervical and then bifurcated into the supraclavicular and then to the mediastinal. And then the B symptoms also support that. And then you got this patient, he got all this stuff. Like he got a really, really great workup. But I think suggesting basically the process of his presentation and some of the things that we've seen here really, it suggests more Hodgkin than it does non-Hodgkin lymphoma.
With that being said, we also have a lymph node biopsy. Yeah. So what do the Reed-Sternberg cells and the positive CD15 and CD30 tell you?
Yeah, so when I have a excisional lymph node biopsy, which is the only way that you can truly diagnose lymphoma, is I'll take those cells, and what you want to know is Reed-Sternberg cells is basically pretty much pathognomonic for Hodgkin lymphoma. So whenever you see Reed-Sternberg cells, it's Hodgkin. Whenever it's like not Reed-Sternberg cells, it could be non-Hodgkin. You just have to figure out which type it is. So once you then just said, okay, I got Reed-Sternberg cells, it's definitely Hodgkin lymphoma. It's not non-Hodgkin. Then from here, I got to determine if it's classical or non-classical. So classical is about 95% of cases, and then non-classical or nodular lymphocyte predominant is about 5%. So it's really low, but you do what's called immunohistochemistry. Basically, all you do is you take the tissue from the lymph node, you run it through this like immunohistochemistry, which is you take like antibodies and see if it tags specific proteins. And if you have CD15 and 30 positive, those are abnormal B cell markers, not usually present on normal B cells. So it indicates kind of a Reed-Sternberg cell. So CD15, 30 positive, CD20, 45, which are normal B cell markers, those are going to be negative. And that really tells me it's a classical Hodgkin lymphoma right there.
And then as far as confirmation goes, it really is a lymph node biopsy.
Yeah,
that's the main way of doing it.
Yeah, you can't really diagnose lymphoma unless you do in this case, an excisional lymph node biopsy.
And sure, his clinical presentation, his symptoms really are all kind of leaning you toward Hodgkin, but then you need to have that lymph node biopsy to say, okay, Hodgkin lymphoma.
Yeah, exactly. So that's the only way that you can truly, just like for example, for most of leukemias, you can't really diagnose it truly unless you get a bone marrow biopsy.
Sure.
The only one that you can potentially not do is CLL, but all the other ones you have to get a bone marrow biopsy to truly confirm. Same thing for this one, you need the lymph node biopsy to find these malignant, lymphocytes that are present there.
All right, so then we're at this point, we have confirmed Hodgkin lymphoma. What other complications could you see with this disease? Because he doesn't look like he has too many at this point, but what are some scary things that could happen?
That's good. So I think prefacing this prior to that mentioning of which kind of complications is, it's important for Hodgkin lymphoma is, if you could get one, it's the best one to get. Okay. So lymphomas, Hodgkin-wise, it's probably accounts for maybe 40% of the cases. Most of the other ones, 60% is going to be non-Hodgkin. Hodgkin has a pretty good prognosis, so overall, it's pretty curative. But there is different subtypes. So nodular sclerosis is the most common. And that one tends to predominate and involve the mediastinal lymph nodes.
And that would be under the classical umbrella.
Yeah, exactly.
Okay.
The other classical ones could be like mixed cellularity. That maybe makes up 30%. And then that one, you see that a lot in Epstein-Barr virus infections and maybe even HIV. The other one is lymphocyte rich. That one has the best prognosis, and then there's lymphocyte depleted. That one has the worst prognosis. So whenever you think about Hodgkin lymphoma in general, it has a good prognosis, but the worst of that good prognosis is lymphocyte depleted. So that's the one where, even though it is kind of a bad prognosis in the sense, it's still something that can be curative. But,
and then you said nodular sclerosis 60, mixed cellularity 30, and then the other two are 5 and 5.
Yeah, they make up the remaining 5%. And then nodular lymphocyte predominant for the non-classical non-classical Hodgkin lymphoma, it makes up a small percentage of the overall, because classical is 95%, non-classical is about 5% of the cases, and nodular lymphocyte predominant is the only one that's really a part of that subtype. We don't really see it too often. And then I think the important thing to remember for that one is you can do the CD15, 30, 20, 45 testing. And for these cells, they don't have Reed-Sternberg cells. They're variants. They're called popcorn cells. And they actually do have CD20, 45 positive. So they have their normal B cell markers, and they didn't transform their other ones. And so they actually are CD15 and 30 negative, unlike Reed-Sternberg cells, which is the exact opposite.
I was going to say that's just flipped.
Exactly.
All right.
Yeah, but I think complications, it really just kind of depends. Usually lymphadenopathy is a big one. B symptoms is a big one. Mediastinal masses is where you got to be careful. If they get pretty bulky, like big enough, greater than 10 centimeters, they can cause mass effect. It's not as common in Hodgkin as it is in non-Hodgkin. Non-Hodgkins, it can get pretty big and they can compress structures. But if it did get big enough and it pressed the trachea, you can get dyspnea, stridor. If it compresses the esophagus, you can get some dysphagia. And if it compresses the superior vena cava, that's where you can get some superior vena cava syndrome. So they get really enlarged, facial neck swelling, maybe some distended veins that you can see there. They can get like some arm and some chest kind of swelling, and they can even have some distended veins in that area. And it can look a little bit rough when you see it. It's not really an emergency unless you start seeing impeding venous drainage from the cerebral system. So high ICP could be a potential complication if they already have like a cerebral structure that's actually kind of a space occupying lesion. They can get hypotension potentially from massive venous return that's being impeded, or compression of the heart, and sometimes even laryngeal edema is a scary one. But those are the big things to watch out for, I'd say, is mediastinal masses. Again, B symptoms are pretty common. Lymphadenopathy is pretty common, and it's usually contiguous. It's a consistent pattern. The only thing I will say, and this is what they like to ask in the textbooks, is that when patients have Hodgkin lymphoma, they get chemotherapy and they get radiation therapy. It's the radiation therapy that you got to be careful for. We give radiation therapy for localized lymphadenopathy. It's really good at hitting that area with radiation therapy to kill those lymphoma cells. But it can cause secondary malignancies because you're hitting things that are nearby. Yeah. So you got to watch out for other kinds of secondary malignancies that can potentially arise, especially like breast cancer, and even like acute leukemia actually can form as well. So those are the big things I think to watch out for, is secondary malignancies due to like radiation therapy can actually, and chemotherapy. So the chemotherapy could actually cause the acute leukemias potentially, and then the radiation therapy could potentially cause like breast cancer. So that's something to watch out for.
Now with Hodgkin lymphoma as a whole, it has a favorable prognosis when compared to non-Hodgkin lymphoma. So how is it treated?
So it depends on the stage. So you got to do what's called like this guy got a, was it a guy or a girl? Sorry.
It was a guy.
It was a guy. They got a PET CT. So they had lymphadenopathy and then multiple enlarged nodes in the cervical and mediastinal regions. Okay. So when you have these lymph nodes that are being involved, you have to then do the Lugano classification. And so you basically take the PET CT scan and you look and say, okay, is there one lymph node region being involved? If that is, that's stage 1. Is there greater than or equal to 2 lymph node regions in the same like side of the diaphragm? So meaning it's like, in this case, let's say it's above the diaphragm. And then stage 3 is you have lymph node regions that could be above and below the diaphragm. And then 4 is it has extranodal involvement. So it involves other areas besides your lymph nodes, like your bone marrow, your spleen, your liver, your brain, your skin, anywhere really, your GIT. If it involves those other areas and infiltrated other tissues, then you're stage 4. So this one tells me that they don't have any extranodal involvement, but they do have multiple enlarged nodes in the cervical and mediastinal regions. So it's greater than or equal to 2 lymph node regions on the same side of the diaphragm. It's above the diaphragm. It's mediastinal. So this would be stage 2.
Now, I have heard of the Ann Arbor staging. So is this just a different type of classification?
It's a modified Ann Arbor staging. Yeah. So it's basically, imagine Ann Arbor. It's been modified and improved. And so we use the Lugano classification
and
now.
Some dude named Lugano came up with it.
Probably, yeah.
Cool.
But yeah, so that's how we kind of determine at first is what stage they are. And so I'd classify this stage 2. And then you can actually subclassify. So you can use, so stage 2, and you can do A, B, X, for example. So A is there's no B symptoms, B is there is B symptoms, and then X is there's bulky disease. So you look at the lymph nodes and measure them, and if any of them are greater than 10 centimeters, you can add an X to it. So it didn't tell me how big the lymph nodes were, so I'm just going to assume it's not greater than 10 centimeters.
Yeah.
But they do have B symptoms, and so I could say this is stage 2B. You know what I mean? So from there, we can determine that. But stage 1 and 2, you do chemotherapy and radiation therapy.
Okay.
All right. So that's, what is it? The ABVD regimen. So adriamycin, bleomycin. You use what's called vinblastine and then dacarbazine. And so those in combination with radiation therapy, hitting the radiation therapy to the localized regions, that should be able to achieve like a curative response, put them in remission. But if they get a little bit more in the aggressive stages, so they get to stages 3 and 4, then we only do ABVD regimen, preferred. In certain scenarios, you can escalate it to what's called the BIACOP regimen. I always got these things. Chemo is intense. When you look at these, and I used to like consult other like hemonc teams and stuff for patients who had underlying malignancies, and that I was seeing them for like neurological or intensive care purposes. You would read their notes and you'd be like, oh my gosh, these chemotherapy meds, they're insane.
Just the amount of acronyms are insane.
Yeah. It's intense.
Everything's abbreviated.
And funny enough, we'll have like a chemotherapy like podcast, but I think the big thing, But the big thing for the be a cop one is that this is really only if they're like pretty aggressive. So I'd say if they really have some extensive like extranodal involvement, it's disseminated, you can use that one. And it's it's bleomycin, etoposide, adriamycin, cyclophosphamide, vincristine, and then procarbazine and prednisone. So it's a lot of those that you're adding on to really help with that process. But sometimes they'll just do the ABVD and they'll do multiple cycles of it as instead. The other thing to do is that you just really want to keep an eye on these patients and then continue to potentially do serial PET CT scans to see if you're eliminating some of those hot spots or the lesions that kind of turn up hot on the CT scan, and see if you're improving that or getting rid of some of those extranodal sites. That's the ultimate goal, is to get this to where you're not really having these lesions light up on PET CT anymore. So that would be the ultimate goal, is complete curative therapy.
All right, well, let's move into non-Hodgkin lymphoma, which is much more common, and of course the prognosis isn't as good as Hodgkin lymphoma.
Yep.
So let's start off with our patient here. We have a 68-year-old male, presents with rapidly growing abdominal mass and intermittent fevers for the past 2 months. The patient reports a painless mass in his left lower abdomen, which has rapidly enlarged over the last 2 months. He has also experienced intermittent fevers, night sweats, and a 15-pound weight loss. He has no significant bruising, recurrent infections, or prior malignancy. For his past medical history, we have hypertension, no known autoimmune disease, and there's been no prior malignancy. Medications, he's on lisinopril. And for his exam, his vitals are BP 130/75, heart rate is 78, temp is 37.6 Celsius, and his O2 sat is 98% on room air. His lymph node exam, it's a palpable, firm, non-tender axillary and inguinal lymphadenopathy. His abdomen, large, firm mass in the left lower quadrant, and his skin, there is no petechiae or ecchymosis present. We do a pretty comprehensive lab and imaging panel. We get the following back: hemoglobin of 10.2, platelets of 140,000, a white blood cell count of 18,000, peripheral smears showing atypical lymphocytes. His LDH is elevated. We do a PET CT and we see widespread lymphadenopathy, axillary, retroperitoneal, inguinal regions. We do a lymph node biopsy for our confirmatory test, and we note large atypical B cells, CD19 positive, CD20 positive. For his bone marrow biopsy, we also do a bone marrow biopsy. We have involvement of the marrow with large B cells. And for his cytogenetics, we have a translocation of 314 and 1418. This involves mutation of the BCL6 and BCL2 overexpression, respectively. Some questions, Zach. Out of all of this information, what do these findings suggest? We know we're talking about non-Hodgkin lymphoma, but what are some things that jump out at you?
So first thing is lymphadenopathy, and it's abdominal mass. That's a little bit more suggestive of non-Hodgkin. But more importantly, I would say, like, when you look at their physical exam, they got palpable, firm, non-tender axillary and inguinal. And then they also have this abdominal mass. So that's very like non-contiguous, right? Yeah. So usually it should start like somewhere like the cervical, spread to the supraclavicular, or then that one goes to the axillary. It can go mediastinal, they can go abdominal, they can go, inguinal. This is all over the place. So we got one in the axillary, and then we got one over in the inguinal, and we got in the abdomen. So it's very diffuse. It's a non-contiguous, you can't predict the spread. So that's super classic of non-Hodgkin lymphoma. That's right away what screams at me. B symptoms. He does have some B symptoms, and so there is some intermittent fevers and night sweats and some 15-pound weight loss. So again, I have lymphadenopathy that's diffuse, non-contiguous, and it's associated with B symptoms. I'm thinking lymphoma. So obviously, whenever you have that, you would go and you would target a lymph node biopsy. And so with this patient, they got a lymph node biopsy, and it showed that there's large atypical cells. They're B cells, so it's a B cell type of non-Hodgkin lymphoma, and we confirm that with CD19/20. Just so for you guys who are listening, you can confirm if it's a T cell lymphoma. So that's the rarer type. It's about 15% of your lymphomas for non-Hodgkin, but it can be T or B. So for the T, it's about 15%. And then there's these components there, which we'll talk about. It's cutaneous T cell lymphoma, and that's because this is a mycosis fungoides, and then how do you say it? Sézary syndrome. Sézary syndrome. So yeah, those usually make up your cutaneous T-cell lymphomas. So you'll have a lot of skin manifestations. And then adult T-cell leukemia/lymphoma, that's usually seen with the human T-cell lymphotropic virus infection. And so we can already throw the T-cell mediated lymphomas out the window, because the only way we tell that is they'd have to be CD3 and CD4 positive, and they don't have that. So that right there helps me to say it's not T-cell lymphomas, and they don't even have any skin manifestations. And so I wouldn't have any pruritic papules or erythroderma, and usually for adult T-cell leukemia/lymphoma, they cause lytic lesions and hypercalcemia. So that's not even present as well. So it's not T-cell lymphoma, it's a B-cell. From there, you have to determine which type of B-cell lymphoma, and they were pretty good. They got like a bone marrow biopsy, which you don't always have to do. You can just do a PET CT scan. The real indication for why you would do a bone marrow biopsy is it showed maybe your PET CT was negative and you suspect that the bone marrow was involved. And how would you suspect that the bone marrow was involved? I would really prefer to see pancytopenia. So I don't really think that this patient completely warranted a bone marrow biopsy. It used to be the older way of doing things, where almost every patient would get a chest x-ray, a CT of the chest, abdomen, and pelvis, and then they get a bone marrow biopsy. We don't really do that anymore. Now we just kind of go at PET CT scans, and then we only do the bone marrow biopsy if they have pancytopenia or if the PET CT was negative. And then we do lumbar punctures only if they have symptoms that suggest like primary CNS lymphoma or meningitis, or that PET CT didn't really show me that. So I really didn't need the bone marrow biopsy, but it's interesting because it shows me that those large atypical B cells that were in the lymph node are now in the bone, and it probably infiltrated there. What really helps me is the cytogenetics, because when we get a B cell lymphoma, I told you that there was T cell, and that was cutaneous, so mycosis fungoides or Sézary, and then the adult T cell leukemia/lymphoma. For B cells, there's mantle cell, follicular, diffuse large B cell lymphoma, Burkitt, and marginal zone lymphoma. And so you have to figure out which one would it be. You can look at the histology, and that always helps. So looking at the biopsy can tell me it's large atypical B cells. But on the exams, you don't often get tested on that. You get tested on the cytogenetics. So you told me it was the 314, 14, 18 translocations, and their BCL6 and BCL2 overexpression was the primary ones that we see. That's almost always associated with diffuse large B-cell lymphoma, especially the BL6 overexpression. If I saw, let's say for example, 814 translocation with an increase in the CMYC, I think Burkitt. If I saw that there was 1114, then I would think mantle cell lymphoma, and that one's associated with increased cyclin D. If I saw 1418 translocation, I'd be associating that with follicular cell lymphoma, and that's an increase in BCL2. If I heard autoimmune diseases like Sjogren syndrome, Hashimoto's thyroiditis, or if I heard they had gastric tumor like a malt lymphoma from H. pylori, it's always marginal zone lymphoma. So things in the history or things in that cytogenetic study would tell me which type of B-cell non-Hodgkin lymphoma it is. And this is really suggesting that it's likely the diffuse large B-cell. And the benefit of that is that diffuse large B-cell lymphoma is the most common type of non-Hodgkin or B-cell mediated related non-Hodgkin lymphoma. So right here, I'd say I'm pretty much like convinced that this is going to be diffuse large B-cell lymphoma.
So with having the diffuse large B-cell lymphoma, what are some complications that you need to be looking out for, and what are some things that are red flags for you to look out?
All right, so first thing is going to be I would like to look for extranodal involvement. And so the PET CT scan would definitely help me with that, right? Because we've confirmed at this point that we know it's diffuse large B-cell lymphoma based on the biopsy. We can determine the stage of it based upon the PET CT scan. So that's what I would want to know. So there's a couple different kind of complications that can happen. One is with extranodal disease, you can involve the central nervous system. So you can get primary CNS lymphoma. That's a really scary one. We see this a lot in patients who have HIV AIDS. It can actually be an AIDS-defining illness. And so sometimes they may come in with a headache. They may come in with altered mental status. They may come in with potential behavioral changes. You'll get a CT scan of the head. You'll see a big mass. You're like, oh my gosh, they have brain cancer. And then you'll go ahead and you'll get an MRI of the brain, and you'll see these ring-enhancing lesions. And that's almost always consistent with primary CNS lymphoma. You can get spinal cord compression. That's a scary one. That can be an emergency. If a patient comes in, they have a history of non-Hodgkin lymphoma, and all of a sudden they're presenting with, they don't have any history of like degenerative disc disease or spinal stenosis or trauma, then you want to be concerned. If they come in with like weakness, sensory losses, bladder bowel dysfunction, could that have spread to their spinal cord, and it's compressing the spinal cord. Another one is the GIT. So you can actually get some of these like spread to the GIT, and you can get bowel obstructions. You can have it spread to the bone. You can get lytic lesions. You can get hypercalcemia. You can get pancytopenia if it infiltrates into the bone marrow. It can go to the skin. It can cause skin lesions, and it can even go in the liver and the spleen. It can cause like hepatosplenomegaly too. So there's a lot of different organs this thing can spread to, and that's why we have to use the PET CT scan to see where it has spread to.
So with the PET CT scan, then how would you then? It's the same classification as before, right?
Same Lugano classification. So yeah, you would say if it just involves like the one lymph node region, stage 1. If it involves greater than or equal to 2 on the same side of the diaphragm, it's stage 2. If it involves lymph node regions on both sides of the diaphragm, stage 3. And if it has extranodal involvement, which is way more common with non-Hodgkin's, that's going to be stage 4. That's why you see more often than not non-Hodgkin lymphoma having a worse prognosis, because it's more has a predilection for those extranodal tissues.
Pretty aggressive then too.
Yeah. And so that's the big thing to remember for that one. Other complications is tumor lysis syndrome. So you can see this with acute leukemias, particularly ALL, more than AML. But you can see with non-Hodgkin's. So if they get chemotherapy and they have all these like tons and tons and tons of like just chunked up tumor cells and lymph nodes and other tissues, and you hit that chemotherapy to it, you can bust those cells open. They release potassium, uric acid, and phosphate. And so you can get acute kidney injury from the uric acid. You can get hyperkalemia causing cardiac arrhythmias. And you can get hypocalcemia because the high phosphate will bind up the calcium. So that's another one. The other thing I would watch out for, and this is a big one for follicular lymphoma and CLL, and we talked about it in the chronic leukemia lecture, is that sometimes in CLL and then follicular lymphoma, follicular is actually an indolent type of non-Hodgkin. So there's actually 2 types of non-Hodgkin. There's indolent, which is meaning it's very slow, gradual, progressive. It's not as severe. That's follicular or marginal zone lymphoma. And then there's severe, aggressive, high-grade lymphomas. These are very, very hyperproliferative. That's going to be your diffuse large B cell, your mantle cell lymphoma, and Burkitt lymphoma. Funny enough, follicular lymphomas can start off gradual, progressive, indolent, and if it undergoes that translocation of 314, it can then transform into diffuse large B-cell lymphoma. So they can actually end up having that problem where they can have what's called a Richter transformation. So you can start off with a very mild lymphoma, an indolent one, and all of a sudden, rapidly enlarging diffuse lymph nodes, B symptoms are getting terrible, and then you end up with LDH really high, you end up with extranodal involvement, and now you have diffuse large B-cell lymphoma. So that's another thing to watch out for. So I'd say extranodal disease, tumor lysis syndrome, and then possible Richter transformations.
Well, now that we're talking about the diffuse large B-cell lymphoma, how is it treated?
So you would treat any kind of aggressive type of non-Hodgkin lymphoma. You would check that CD20. Was our CD20 positive?
Oh, yeah.
Yeah. So in order for you to have you have to get the CD20 that's positive. You would do what's called a rituximab-based chemotherapy. So it's R-CHOP. And we would do rituximab, cyclophosphamide, hydroxydonorubicin. We would do Oncovin, and we would do prednisone. And these are going to be the ways that we would treat a patient who has this type of process. And again, diffuse large B-cell lymphoma. We could do diffuse large B-cell lymphoma like this. We could do mantle cell lymphoma like this. You can consider Burkitt lymphoma with this one. Sometimes they do the CVAD therapy that we talked about in the acute leukemias lecture. But R-CHOP would be the primary gold standard for this patient if they have an aggressive non-Hodgkin lymphoma. If it's indolent, we can just do rituximab, as long as they're CD20 positive. So you always have to make sure that they're CD20 positive, because if not, rituximab won't work, because rituximab is a monoclonal antibody that literally targets the CD20 and then literally causes your immune system to kill those lymphoma cells. And so we would really need them to be CD20 positive. For patients who have diffuse large B-cell, an aggressive non-Hodgkin lymphoma, diffuse, Burkitt's, mantle, they have HIV, and they have other tissues that are extranodal tissues that are involved. The testicles, the portions of your spinal cord, the epidural or the meninges, those patients are super high risk for CNS infiltration. And so in those states, we actually have to do CNS prophylaxis. So we had to put in either an Ommaya reservoir, or we do a lumbar puncture and we squirt in chemotherapy. You would think, oh, can you just give them the systemic chemotherapy, the R-CHOP, and it'll cross the blood-brain barrier? It doesn't. And so you have to give them chemotherapy that you actually put into the cerebrospinal fluid, that you prevent them from developing primary CNS lymphoma, meningitis, spinal cord compression, and all those things. And so that's where I would add in the intrathecal methotrexate, only if they have an aggressive, high-grade lymphoma, non-Hodgkin's, HIV positive, because that puts them at super high risk for primary CNS lymphoma, and then if they have multiple other extranodal sites that are involved, particularly the testicles are a big one. And then again, we say around the actual vertebrae, around the epidural spaces. These are really, really sensitive areas. And even for some weird reason, the paranasal sinuses. If they're near those areas, these patients are super high risk for some type of like CNS involvement, and we just want to get them on intrathecal methotrexate. The last thing I would say is if a patient has really bad lymph nodes, like they have superior vena cava syndrome because they have a mediastinal lymphadenopathy that's compressing on that area, we could do radiation therapy. And if they have spinal cord compression from like a bulky kind of like tissue compressing on the spinal cord, then we could do radiation therapy for those as well.
And that would probably be more so with the T cell one, right?
You could do it. It could be in the T cell. You can't see it with T cell, but you can also see it in B cell.
Oh, okay.
Yeah, so you can see it in both. But yeah, spinal cord compression, scary one. Steroids are usually the upfront, and then radiation therapy. You'd have to reach out to your radiation oncology colleagues. And the same thing, if you have superior vena cava syndrome, I do steroids, maybe stent them if it's really, really bad. But ideally, it would just be getting them some radiation therapy to kind of decrease the size of it rapidly.
All right. Well, we talked a ton about Hodgkin versus non-Hodgkin lymphoma. I would say before we end this episode, is there any quick and awesome key takeaways, high-yield points that you can differentiate the two?
A couple of different pearls that I would say to take away from this is that Hodgkin lymphoma, again, you're going to want to look for that lymphadenopathy that's usually predictable. It's usually cervical and then spreads in a contiguous manner, and it's almost always associated with B symptoms. Also remember, it can cause mediastinal masses, and again, that's usually the nodular sclerosis subtype. Biggest thing with this one diagnostically is when you get a lymph node biopsy from that big swollen lymph node, if you see Reed-Sternberg cells, it's Hodgkin lymphoma. And then if you figure that out, boom, you just start off by saying, okay, what stage are they? Are they stage 1, 2? That's ABVD, chemotherapy plus radiation. If it's stage 3, 4, it's just usually just ABVD by itself. For non-Hodgkin lymphoma, you want to look for lymph nodes that are really, really enlarging pretty significantly, but again, they're not in a contiguous manner. They're really unpredictable. They're diffuse, so you may have it in the cervical, and then you also may have it in the axillary on the other side. You may have it in the abdominal. You may have it in the inguinal. So it doesn't really make sense the way that they're spreading. And then again, they can have B symptoms, but extranodal disease is the classic difference. Look for CNS involvement, skin involvement, GI involvement, bone marrow involvement, liver and spleen involvement. If you see that, it's way more likely it's non-Hodgkin. Again, with these, they can get pretty bad, but if you figure out from their lymph node biopsy that they don't have Reed-Sternberg and they're atypical malignant lymphocytes, you just have to discern, is it B or T? Look at the CD proteins, and that should identify it. But again, the biggest thing from this is once you've identified that it is non-Hodgkin lymphoma, you treat that appropriately. If it's your aggressive subtypes, you treat that with the R-CHOP regimen. If it's the non-aggressive or indolent subtypes like follicular or marginal zone, you treat that with primary rituximab therapy. Only thing I will add is if it's marginal zone lymphoma, you can actually treat that without chemotherapy at all. And that is really important to remember that we consider this in patients who have H. pylori, gastric malt lymphomas. We actually just treat them as though they had peptic ulcer disease from H. pylori.
That's good to know.
Yeah, the quadruple therapy. Yeah. Because you're just kind of reducing the risk of recurrent immune activation and then causing them to have worsening gastric malt lymphoma. So that's the biggest thing. And I would say always monitor for the scary, scary complications in these patients, especially non-Hodgkin's. Watch out for CNS involvement. Watch out for tumor lysis syndrome. Watch out for any kind of like spinal cord compression. And those are the big things I would say to take away from this.
That's awesome. That was a really cool episode. That was quicker than I thought.
Yeah, I think lymphoma, a lot of the times when it comes down to it, it just starts off with a big lymph node and some B symptoms, and you just kind of work down the process of there. Is saying, okay, is it Hodgkin, non-Hodgkin? And then if it is, how do I treat this? Yeah. And that's really what it comes down to.
Awesome. Well, it was super informative. Thank you.
Yeah, thank you guys. And I hope that you guys liked this podcast. I hope it made sense. I hope that you guys enjoyed it, and love you. Thank you. And as always, until next time.